Okay, let me know if you are not adequately seeing this. Otherwise, I'm going to try to have my chat up to view questions on my iPad, but mostly focus here on this screen. So thank you all for joining us. For those that have been in any of the 3 previous ones, so our first one was about overall safe prescribing of benzodiazepines. The second one about contraindications in at-risk populations. The third one was about benzodiazepine-induced neurological dysfunction. And this final one about de-prescribing and tapering of prescription benzodiazepines. So I'm Dr. Alexis Ritvo. I am an addiction psychiatrist and assistant professor of psychiatry with the University of Colorado, and co-chair of the Benzodiazepine Action Work Group with the Consortium. And we invite any of you to join us that are interested in the issue of prescription benzodiazepines and their safe prescribing and de-prescribing. We meet the first Tuesday of every month at noon online, and on the Consortium website, there's a way to sign up for the group emails as well as to join the group. And then I will let my friend and colleague, Dr. Jeff Gold, introduce himself and start with the presentation objectives.
Pleasure to be here again. Again, my name is Jeff Gold, Dr. Gold, and I'm a clinical pharmacy practitioner in psychiatry at the VA Medical Center and senior instructor at the School of Medicine for the Department of Psychiatry. I've co-founded the Benzodiazepine Taper Clinic at the VA many years ago with Dr. James Haug, who's an addiction psychiatrist, and have been interested in benzodiazepines for a number of years, and it's a pleasure to conclude today's 4-part series.
Got to be on the right screen.
Okay, there we go. Today, what we're going to talk about is de-prescribing and the tapering of benzodiazepines and all the different things that come up therein related to withdrawal, as well as techniques and other things that we can use to facilitate the tapering process. We're going to talk about utilization of motivational interviewing to discuss tapering with patients. We're going to talk about the withdrawal symptoms. We're going to describe the advantages and disadvantages of different strategies and approaches to tapering benzodiazepines. We're going to talk about some of the adjunctive treatments, medications, and therapy that can be used to help mitigate withdrawal symptoms and throughout the tapering process. And finally, we're going to look at the Benzodiazepine Action Work Group De-Prescribing Tapering Guidance. Next slide.
I apologize. Of course, right as I start speaking, there's some loud thing going on outside, so hopefully it's not too distracting. So I'll start by talking about how we can utilize a motivational interviewing approach to discuss actually any behavior change we want to approach with our patients. But I think this is a place where it's particularly useful. So motivational interviewing, which was initially developed for substance use and then has since been applied to a whole variety of behavior changes in healthcare settings and has a great deal of evidence behind it. So it is a directive, client-centered counseling style for eliciting behavior change by helping clients to strengthen their own internal or intrinsic motivation and commitment for change by helping them explore and resolve their ambivalence. So overall principles in motivational interviewing is the importance of expressing empathy, and you can do this by using reflective listening. So really working on reflecting back to patients what you hear them telling you, helping clients develop discrepancy between their goals and values and the current problem, behavior, or issue, using that reflective listening and objective feedback, avoiding argumentation by assuming that the client is responsible for whether or not to make the decision to change, rolling with resistance rather than confronting or opposing it. I think we can often, especially as prescribers, end up in this place where we feel like we know what's right. I know I certainly experienced this as a parent, and it's easy to want to just tell people what they should do. This is called the writing reflex. And intrinsically, and I think thinking about, in my case, toddlers or adolescents, we can see this at work. When you tell people what they should do, even if they know in part that might be what they should do, their reaction is to kind of put up a no but and tell you why they're not going to do that. And then supporting self-efficacy and overall optimism for change. So I took this table. There's just a whole plethora of good literature out there. The creators of motivational interviewing are Miller and Rolnick. This is an article that I think, if I remember, Emmons did with Rolnick about applying motivational interviewing to behavior change in healthcare settings. But I liked that this just gave some examples of ways to ask questions of patients, trying to understand initially when you approach them of something that you want to, when you want to engage in this discussion with them. So the importance of using open-ended questions to try to understand what they're experiencing and their concern, and to really trying to understand their perspective and their experience. The importance of asking their permission to discuss a specific topic. In this case, you know, would you be willing to talk with me a little more about your history of having a prescription for a benzodiazepine and your experience with it? Assessing their readiness to change. There are even things called, you probably have heard of, like readiness rulers, motivation rulers, and where you can talk to someone about, on a scale of 0 to 10, how motivated are you to change? And then you kind of assess, well, what makes you a 5 and not a 2? And that's kind of to put it in the positive terms of what their current motivations are, and what could help make you a 7 instead of a 5. So how can they think through what could be additionally motivating for them? Providing feedback, again, asking permission. If you have some information, say you do a cognitive screen and it comes up with some unexpected results or lower than you would expect abnormalities, asking them first what they make of these results, then asking, do you have permission to share some of your thoughts of what could be contributing to this, some ways you could potentially address or see if there's some reversible causes for those changes. And then offering ongoing support, even if they're not at a point where they're ready to change, asking if there's any other additional information you can provide them about this topic, what they currently think they would need to know or have happen for them to be in a place where they would be willing to consider making a change. And if they are ready to make a change, first seeing what they think would be most helpful for them, and would work best for them. And then again, asking permission, can I tell you some of what we do know has worked for people, or some of the different approaches we can take, and some of the resources out there. So again, this could be a whole course really in and of itself. And there are some great motivational interviewing courses, good both references for free that are available online. I really like, although you do have to pay for it, the founders of motivational interviewing do an online course through, I think it's PsychWire, and I just really find their explanations and their brief videos, and for an online course, it's very interactive. So, and also you can get CME for it. So go ahead.
I want to talk a little bit about the Empower trial. And this is just to really suggest, I think, some of the concepts of motivational interviewing in practice. But the Empower trial looked at direct-to-consumer advertising regarding benzodiazepine use in individuals age 65 or older. And essentially what they did in these studies, and there have been a number of follow-up studies that resembled the Empower as well, but they sent information to patients taking benzodiazepines about their risks. And if somebody were to decide to taper, what the taper would look like, what would be the purported benefits of tapering the medicine. And they included all sorts of educational information in these brochures. And what they found is that the direct-to-consumer approach led to a 27% intervention group where people were able to taper off the medications or engage in the tapering process, compared with 5% in the control group. So there was a much greater degree of engagement in tapering when patients were provided education about the benefits of tapering and a really clear explanation of what the tapering process would look like. Next slide.
So overall, when thinking about the indications and benefits of de-prescribing, and just to highlight, we use de-prescribing. The other term people are often familiar with is tapering, but I think in this case, we're talking about a medication that has been prescribed, and we're wanting to engage in a process of decreasing it or de-prescribing it. So indications would be overall any adverse effects from the medication, limiting function, loss of its efficacy, increased tolerance, use beyond the generally indicated month, and a patient request to taper. The benefits from a taper is that for many, it actually can contribute to reduced anxiety, especially if folks are experiencing interdose withdrawal symptoms of anxiety or rebound anxiety between doses, improves psychomotor and cognitive function, overall reduced mortality, both from all causes, overdose risk, and motor vehicle accidents, as well as falls and drug interactions. And so you can see, I mean, several of those, especially psychomotor, cognitive, and many of the all cause are some of them that really increase with increasing age and the changes in metabolism. At the same time, some individuals that have been on benzodiazepines chronically might develop certain symptoms, physiologic, psychologic, that lack any good alternative explanation. And some have found that these improve upon engaging in de-prescribing, either by decreasing the dose or ultimately getting off. And this, I think, falls in line with what we discussed last time, and we'll touch again briefly on today about the benzodiazepine-induced neurologic dysfunction. The risks with de-prescribing is, one, the symptoms of withdrawal that folks will experience. So we know, and again, these estimates, as you'll see, are wide ranging because it is a hard thing to kind of capture in a study, but somewhere around 15 to 44% will experience moderate to severe withdrawal symptoms upon discontinuation, especially when it's been taken beyond that month or even consistently for 2 weeks or more. We know that, as we discussed in the previous presentations, factors that can increase the difficulty of the withdrawal is overall, if someone has central sensitization, also known as kindling. So if someone has been using a benzodiazepine and repeatedly made attempts to either abruptly stop or cut back too quickly, each time that's done, it has an effect of kind of making the nervous system more sensitive. We see this with other medications. We see this in folks with alcohol use disorder, where the likelihood of experiencing withdrawal symptoms increases, that it will be sooner and more severe, and potentially with less even decreases in the medication, or for some folks actually before they've even began to decrease the medication. We know that an estimated, and again, I think if we engage in more research, this number will probably go up, but at least 10 to 15% experience a protracted syndrome that lasts months to years, and for some maybe indefinite. This is what we now want to place a new name on, of the benzodiazepine-induced neurologic, and I put this wrong, neurological dysfunction. We don't yet have clear symptoms categorized by research to call it a disorder, but we are calling it dysfunction. And this can occur even when you do engage in a very gradual taper. That we can have severe outcomes from de-prescribing, even when done gradually, including increased suicidality, akathisia, which is an inner sense of restlessness, and overall disability from persistent symptoms, really a myriad of symptoms. And that there can be an understandable significant amount of fear and ambivalence about no longer being on a benzodiazepine for a variety of reasons, whether it's for the reasons that an individual initially was started on it, the sense that it does provide some relief or improvement of their ongoing symptoms, or the concern that even though they are worried or find that there are certain effects they're experiencing from it or think they're experiencing from it, that they will feel worse or be even more disabled trying to decrease or come off of it.
One of the important parts of this, as Alexis described, was working with patients to make decisions about coming off these medications. It's very difficult to come off these medications. Even when people want to, they can often be very ambivalent. They've read the benefits of being off said medications to their mood, to their function of their mind for the rest of their life, but yet they might fear not having the medication to sleep, for anxiety, for a variety of different conditions. And so de-prescribing should really be, and when it's at its best, a collaborative discussion between the patient and the provider. And there should be lots of discussion about why we're doing this, how it's going to look. I'm certainly a big fan of the shared decision-making model. I like to talk to the patients about, are you ready today to make a reduction in the dose? When do you think you might be ready? Like, what are some of the things that you're afraid of going forward with the taper? What are some of the things that you're noticing improvements in how you're thinking or feeling as you're coming off the medication? Really utilizing a lot of those motivational interviewing techniques, I think, is extremely helpful. Even defining ambivalence for patients while they're in the midst of the taper process is very useful. And when they say, the part of me that is encouraged about this feels these ways, and I really try to get them to think about what are all the things that their goals and what are they hoping to achieve by coming off the medicines. And in general, forced tapers are not recommended. And this is not something that I routinely do. I only force tapers if there's a really explicit and clear safety reason. For example, I find through a urine drug screen that somebody is using illicit opioids. And I have an explicit concern about their safety. And then I look at a more direct taper that has to be done over a shorter time period. But in my clinical practice, I've only done this a handful of times. And so I'm really working with the patient through and through, making sure that it's as comfortable for them as possible. And they understand every step along the way of what we're doing and why. If de-prescribing is declined or attempted, or it's too difficult, you really need to have close follow-up. You can't just stop these medications. The withdrawal symptoms can be very severe. And oftentimes I ask folks, do you want to take a break? If this is becoming too difficult, do you want to stop for a little while? And when would you want to restart? And what would restarting look like? And sometimes there are folks who never quite get off of the medicine, or they do, and they feel much worse even after several months. I will continue to follow up with them for months after the medicines have been stopped. And I've had people who have gone back on a small amount. And of course, this isn't ideal, but sometimes I think that the idea is that the goal is their quality of life and their ability to function and participate in their life. So I think this is really getting at the idea that it's not one size fits all, and that you're working with the patient to come up with a plan that works best for them and that you feel that is safe. This is a piece that I wrote alongside a colleague of mine for the College of Psychiatric and Neurologic Pharmacy. And essentially, I'll read it actually. The fear of coping without a benzodiazepine plays a major role for many patients when tapering. Unresolved issues that long-term drug use has masked often return and are painful. Tolerating painful feelings and the associated anxiety that have been numb for a significant period is a challenge, and such patients have become conditioned to the use of benzodiazepines for coping with these feelings and anxiety, and may find the normal range of the feelings to be overwhelming. It is often a major component of their resistance to taper. Thus, providing a safe place to talk about this experience is essential. Consider recommending psychotherapy, particularly when these patients have had significant anxiety or mood changes, and watch carefully for other substances during this time. Now, I want to say that I'm fully aware that many patients taking benzodiazepines do not have pre-existing mental health concerns or psychiatric disorders. There are many people who find their way to using a benzodiazepine, but the period of coming off of the medicines is so difficult and can bring out a whole host of different feelings that having extra support around this time is really critical. And I think this highlights just the challenge of coming off these medications, regardless of what their initial indication was for, and making certain that you as a provider are offering lots of adequate support and are offering resources during this time. I've certainly had people who've taken benzodiazepines long-term for even something such as insomnia, that as they come off the medication, feel like they've had a new onset of anxiety that's unfamiliar to them compared to the rest of their entire life. Next slide. We're going to talk a little bit more about withdrawal, benzodiazepine withdrawal. And we see withdrawal typically when a benzodiazepine is used for 2 to 4 weeks or more. And really all benzodiazepines, when they've been used for longer than that period of time, should be tapered. Some of the greatest chance of having significant withdrawal symptoms is when folks have used benzodiazepines for a long time on a scale of years, months to years, or when they've used high doses of such medications. And also during this time, when people are coming off these medications, pre-existing psychiatric conditions, if people have them, can be greatly exacerbated, particularly insomnia and anxiety, but any number of different experiences that folks have. I've seen patients with bipolar disorder develop manic symptoms. It's just a period of where you want close follow-up and education around what the patient should be watching for in the context of maybe a previously diagnosed psychiatric condition. There are also so many different physical and psychological effects as well. And really, I think the hallmark here is that you never want to abruptly discontinue these medications, even when a patient feels comfortable stopping the medication, or they say, "Oh, I don't want to go through with that, doc. Please just let me stop." I don't let them talk you into that. I've had a number of people who, particularly working with the veteran population, who are just some tough old birds, and they do not want to taper the benzodiazepine. They're like, that sounds like a lot of appointments. That sounds very complex. I don't want to do that. And it really needs to be explained to them that this is something that you must do unless you have really significant medically complex withdrawal symptoms that can be severe in nature. I will tell you that in my clinical practice, after seeing benzos abruptly discontinued, I've seen psychosis. I've seen, unfortunately, suicide. I've seen one instance of somebody having a seizure when they were stopped off of 12 milligrams of clonazepam without tapering. So these are real potential effects and can be life-threatening. There are a number of benzodiazepine withdrawal rating scales that can be used, and 2 such scales have been developed and specifically to evaluate benzodiazepine withdrawal. There's the CWB. These are just some simple questionnaires that can be used. And there's also the Benzodiazepine Withdrawal Symptom Questionnaire. And without going into these in detail, I think that they actually can be useful. For many people, it's easy to see, just kind of track their own progress, or to have some objective measure for both you and the patient to look at as you're tapering. I don't routinely administer these at every appointment, but in the past, and for certain people, I think it's really easy to show them, or to build confidence, and also just to be objective in terms of what you're evaluating. If somebody is telling me that they're very comfortable and the taper has been relatively uncomplicated, then I typically will not use such rating scales, but they can be very useful. Alexis, do you use these routinely? Oh, you're muted.
Sorry, I had to sneeze, so I muted myself. I don't routinely. I've used them more when I'm worried about someone's sensitivity to a cross taper from the short to long acting, and want to make sure we're not missing acute withdrawal symptoms that are putting them at risk for worse symptoms, or if there's some reason someone does need to or have to engage in a shorter taper, I'm more likely to use them. But I think they're a useful tool to know about. Well, of course, knowing they're capturing more the acute withdrawal symptoms.
Yeah, and I think that's pretty my experience. If I transition somebody from, let's say, Xanax to Alprazolam to diazepam, that's a time where I might use it. Or if somebody's having a complicated with tapering process where they're having lots of withdrawal symptoms routinely, it's helpful to kind of track the different domains. In general, benzodiazepine withdrawal occurs in 50 to 80% of people who take these medications for longer than 6 months. And the acute phases we've talked about can develop into the protracted phase, which can last months, years, or even turn into a bind, as Dr. Ritvo has discussed. Next slide. The acute phase of withdrawal generally may persist for anywhere from 5 to 28 days, generally peaks after 14 days. And after this time, most symptoms should return to the extent that they were prior to discontinuation. And benzodiazepine withdrawal syndrome includes symptoms that are common to many anxiety disorders, but also can look some various things that are specific to benzodiazepines. I'll jump to the next slide here. Some of the most common would be anxiety and panic attacks. That's as well as insomnia. These are the things that I would say I hear the most commonly from the patients I work with. And just to put this in context, acute withdrawal would be you're tapering somebody, you're meeting with them on a once every week or once every 2 week basis or once every 4 week, but doing maybe phone call check-ins once every other week. And you're doing it in very sequential, slow, methodical increments. And even yet still, people can experience these acute withdrawal symptoms. And those would be the most common. I also have heard a number of people describe weakness or tremor, sometimes an electrical sensation that runs through people's arms and legs, or the sensation that your muscles are twitching on their own. A lot of GI distress, feeling nauseated or very uncomfortable. Rarely, and if abruptly discontinued, people can experience perceptual disturbances, including psychosis. Again, this would be more in the context of somebody who is stopped abruptly, which again can lead to all these things, times 100. It could be very severe, lead to significant medical consequences, and just should never be done. In fact, there was the gentleman I spoke of earlier who had a withdrawal seizure. Without getting into giving the story for an example, but one of the things that was very complex in the situation is that this person was put in jail for driving and appeared impaired and did not, and the reason why they were not given the medication when they should have been given the medication, why it was abruptly stopped, was because they were in jail. And now I believe there's a lawsuit involving the state for negligence. So hallucinations, seizures, those would be rare things, but can happen if they're abruptly stopped. Other more common side effects or withdrawal effects during the taper and a careful taper process might also be tinnitus. And the ringing of the ears is not uncommon whatsoever. And again, just a general strange tingling, numbing sensation, just the quality of touching things feels different.
I will add, I have seen psychotic symptoms more likely like in elderly, even when engaged in a slow taper, but that have been on something for a super long time, probably because also maybe as part of a delirium picture, and occasionally in other folks with too rapid of a taper, even if it's done, in what's thought to be a relatively safe rate, like closer to the 25% reduction. So I think sometimes we just don't know. We certainly know some people that are more likely to be sensitive to it if they have a reason for having an impaired brain, a risk of psychotic or mood disorder like a bipolar picture, on other psychoactive substances. But I think this will speak to why our guidance about always trying to start with a very small reduction to see how someone does, because we just don't have the research yet to really say why some individuals, short of the kindling and an otherwise affected brain, are just much more sensitive to the withdrawal.
I was going to say briefly too, I have permission to share the story. It was a court case I was involved with, and I know I discussed with Dr. Ritvo some time ago, but it was a gentleman who had taken 4 milligrams of lorazepam at night to sleep for over 15 years, a lawyer, no previous psychiatric history. And he went to a pain clinic, was having some spinal problems, and was prescribed opioids by a provider. And that provider said, I don't prescribe opioids and benzos together. And she said, you could stop the lorazepam. And within a 6-week time period, it's unclear exactly what happened. He had, for the first time in his life at age 59, developed psychotic symptoms, and unfortunately took his own life. And this never had it been so clearly documented to me, like what withdrawal psychosis could look like.
Mm-hmm. Yeah. So talking about protracted withdrawal, which of course now this is what Ashton initially referred to it as, and now we're kind of moving towards trying to say it's kind of more complex and potentially even longer than that, and putting forth the name, the benzodiazepine-induced neurological dysfunction. But knowing that, it's extremely hard for patients because often this is not yet well understood by the medical community, not well known and identified, and it takes such a huge variety. Recently, the parallel I really like to draw, and I didn't put in here this diagram I found, I think it was a Nature article, but is to what we're seeing with long COVID. So here you have this entity, and I think the fact that long COVID has onset at such high numbers because of course, how acute COVID has been, that, that there's more reason to really be like, oh, wow, this is really affecting a lot of people, even though it takes on so many different symptoms and forms and range of severity for folks. But given how quickly and how many people it's affecting, it's hard to say it doesn't exist. And I think that it's similar, of course, except for in this case, it's caused by a medication we have prescribed and not a virus. We just haven't had as much research into understanding why for some people. So it can be difficult for patients to really determine what the symptoms of withdrawal were that existed maybe even before tapering, but knowing that some people do identify that they're already having some symptoms and trying to figure out, are these the symptoms related to some sort of protracted withdrawal or ongoing withdrawal from the medication versus the initial symptoms that I might have been experiencing that I started the benzodiazepine for in the first place. That people can describe these symptoms, as I already mentioned, while actually taking the medication. And I know Dr. Huff did a great job of describing how she realized that even with what most of us would consider a pretty low dose. I think she said started on 0.25, maybe got up to 0.5 of Alprazolam, and a severe anxiety that I know some refer to as almost a chemical terror, which I think captures it well, that is beyond even maybe the anxiety they previously experienced. For some, these symptoms can disappear or return to pre-discontinuation levels weeks or more after they get through acute withdrawal, and may find they continue to decrease. And I will say, on the one hand, we want, again, we don't yet know how to predict the folks that are going to have the increased sensitivity and the more prolonged and severe course, and which is why we want to proceed so cautiously. And I can say, having worked with a number of individuals, I do have many patients who do very well with tapers and are able to do them in a shorter course of time, and do well and say, and they're the ones saying, no, I'm ready to go to the next step, and I want to get off these as quickly as I can, as safely as possible. But it just, there's this huge variability, and we don't have it well characterized yet. And there are folks that after discontinuing will really say they notice actually their anxieties improved, their moods improved, and certainly cognition and memory. And so, and I think I mentioned this, I had a patient on, I think, 1 milligram of clonazepam for, I think it was only a year or so, came to me on that. We were worried about Parkinson's and a possible like a dementia, given an abnormal MoCA. And actually upon tapering it over the course of a few months, her MoCA went back to normal, and memory went back to normal. So you can really see that. But again, there are some folks, and our best estimate being is 10 to 15, but I think probably we're missing folks that get removed from the medical system because they don't feel believed and aren't getting the care that they deserve, that decline, feel their symptoms decline but never disappear, that experience what's referred to as the windows and waves of the symptoms, where they episodically reappear, probably in the setting of certain physiological, stress or distress, and others where the symptoms linger for years and may remain severe and impairing. This is a list of protracted withdrawal symptoms that the Ashton manual puts forth, certainly, and what she saw of overall usual course for many of them. And so it's a useful place to start. And I know many people where it was finding this list that felt so validating and reassuring that what they were experiencing was real, and someone had actually seen this and documented it. But certainly we've seen, and as was reported in the bind presentation, the list is even greater than this. So again, I won't, we want to get to other things, but do just want to say, this is why we're putting forth calling protracted withdrawal actually a benzodiazepine induced neurological dysfunction. And at least I got it right on this slide. And these are slides that Dr. Huff and Dee Foster, my co-chair, created, but I thought did a good job of just reminding us, bind is not acute withdrawal. Doctors often train to look for symptoms of acute withdrawal, which is the process of the drug being eliminated from the body. Other terminology has been protracted or withdrawal, post-acute withdrawal syndrome, persistent prolonged withdrawal, benzodiazepine withdrawal syndrome, benzodiazepine injury syndrome, benzo brain injury, and many others. And that the definition we are kind of putting forth is that this is a constellation of functionally limiting neurologic symptoms, both physical and psychological, that are the consequences of neuroadaptation and or neurotoxicity to benzodiazepine exposure. These symptoms may begin while taking or tapering benzodiazepines and can persist for weeks, months, or even years after discontinuation. From the survey paper, they came up with up to 14 categories, 7 psychological and 7 physical, of symptoms that were endorsed by individuals. Actually, sorry, not the survey paper, but Ashton and then in his book also showed these. And in a recent survey paper, these were the ones, the top symptoms endorsed by individuals that they continued to experience. So sleep disturbance, low energy, difficulty focusing and feeling distracted, and first and foremost, nervous anxiety and fear. Next we'll kind of get into the overall advantages and disadvantages of different medical approaches to benzodiazepine deprescribing. I forget, Jeff, are you doing this part? I am.
You do this part, yeah.
Okay. So before tapering, I think goals for a successful taper are to overall decrease withdrawal effects, manage rebound symptoms, and as well as the recurrence of any underlying symptoms that were initially being managed or the reason the benzodiazepine was initially prescribed. To use shared decision-making with the patient to establish a flexible and gradual taper plan, to discuss other lifestyle modifications such as diet, exercise, sleep hygiene, meditation, and stress reduction to help with the symptoms of benzodiazepine withdrawal, to establish peer support system using a multidisciplinary approach. And we'll encourage folks to check out our peer support document that is available on our work group webpage, along with the other guidances that has some good information about existing peer support. And that before tapering, that you stabilize the current dose of the benzodiazepine and address interdose withdrawal. And that 2 different ways to do this would be, so you're assessing overall, how is someone currently taking their benzodiazepine, walk you through it. And we're really trying to make sure it's scheduled and not taking here and there based on when someone's experiencing more anxiety or more withdrawal symptoms. And then kind of, we don't have good evidence for one approach versus the other. So some of it comes down to initial personal preference, as well as if someone's older, we want to avoid initially trying to put them on too much long acting just because of their change in metabolism. But the options are to substitute an equivalent dose of a longer half-life benzodiazepine, most often diazepam because it's the most available. And actually this shouldn't say clonazepam because we don't substitute that because that is more potent. It should say chlordiazepoxide and chlorazepate. So I'm not sure how that got in there. And that this is not, you don't do a direct substitution, you do a cross taper. The risk is if, there's imperfect cross tolerance and you need time for the longer acting to build up. And if you don't give that time, you risk someone experiencing acute withdrawal and even worse, even buying symptoms as they do this cross taper. The other option is you take the short half-life benzo that they're already on and see if it needs to be dosed more frequently. So if someone's on Alprazolam 3 times a day, I might move it to 4 times a day, taking their current dose and just finding a different way to divide it based on the formulations that are available. So again, overall symptom-based, patient-directed is the best approach for the vast majority of patients, barring other complications like an acute medical issue or someone that's developed addiction, whether it's to benzodiazepine or other things, and can't manage a symptom-based, patient-directed approach. Doing a test reduction in the smallest increment possible. So if possible, less than or equal to 5% of the current dose. I will say, depending on patient's insurance, the different formulations available to you through the formulary and a patient's level of both health literacy, support, and other things really determines what is possible. As we talk about some of the more complex ways to approach this, I will say I've had some patients where, because of either their cognition, their social support, health literacy, you have to adapt and do what is going to be the most feasible, and they're going to be able to follow safely. Allowing the patients to lead the dose reductions and the intervals based on their tolerability. Certainly, I would not make a change any more often than I usually go for 4 weeks, and unless the patient becomes motivated or desires to try more, less than 4 weeks because they're really tolerating it, then go to 2. But really want to make sure you're giving it time to reach steady state and for any severe withdrawal symptoms to stabilize more. And that overall, when you look at the information from the lived experience, that really the 5 to 10% reduction of the total dose monthly tends to be the best tolerated. Trying to avoid skipping doses, taking rescue doses, or updosing, because then you risk kindling of the withdrawal effect because you're changing the dose and then decreasing and increasing. However, slightly increasing the dose may become necessary if it turns out that the reduction that was done was too much and there's severe symptomatology. So I've seen this, akathisia, suicidality, psychosis, delirium have all been reasons I've seen people reinstate even coming off, especially when you get down to the lower doses, have reinstate a small amount of the dose. And so overall, keeping in mind that the dose reductions you do will need to become smaller amounts as the taper progresses. And that's because, we want to be thinking in percentages and not doses. The other thing is not only even percentages are not fully accurate of what's happening on the receptor level, because you can have linear reductions in the amount, and at some point, the amount that affects the target receptor is going to be greater. So this is why for almost the vast majority of medications, it is harder to get off the lower doses because those are still occupying a large percentage of receptors. And this is a diagram I really like that Horowitz, who's a psychiatrist who himself experienced some severe withdrawal from discontinuing an antidepressant and has since looked at antipsychotics and certainly comments about benzodiazepine, but hasn't studied them as much yet, but shows, when we're thinking about how to decrease the medication, why doing these smaller dose reductions is better as far as giving more time, more ability to adapt to the new homeostatic set point with the drug and not cause as big of a decrease.
There's some general techniques that we're going to discuss. We've discussed about stabilizing the dose before tapering, minimizing the use of rescue doses, PRN doses, and really getting the patient to use a consistent amount of medication before beginning the taper. So stabilizing the dose, address interdose withdrawal. And remember, defining interdose withdrawal more clearly is when people have withdrawal symptoms between taking doses of the medication, and switching abruptly, not recommended. You want to do a more of a gradual transition of one benzodiazepine to another. There's something called cross tolerance, as Dr. Ritvo discussed, which is where You can actually, by giving somebody the equivalent amount of the same medication, you actually can give them more. There's generally like a little bit less sensitivity to the new medication, even when used at like a equivalent dose. In general, in my practice now, I don't always convert people to diazepam. I do not always do that. I sometimes gauge how comfortable they are with the benzodiazepine that they're taking and see how comfortable they are tapering that. But if we get to a point where I'm not able to make further dosage reductions based upon the formulation of the benzodiazepine that they're taking, then I'll convert them to diazepam. The one exception is Xanax. With Alprazolam, I generally find that it's a smoother taper for the patient if they transition to diazepam. I've had several patients who said they wanted to be tapered off using Alprazolam, and I've agreed to do this based upon their comfort. And one such patient eventually transitioned to diazepam, maybe about 70% through the taper. He was just having such significant withdrawal symptoms. And when we transitioned him to diazepam, he said, and I share this with everybody who I have this conversation with now, he said, I wish you would have convinced me to transition to diazepam months ago. So I tell people that story. I do think it is a smoother transition, steadier blood levels, as Dr. Ritvo suggested. Many practitioners continue to follow recommendations suggesting conversion from shorter to long-acting agents, but the data on this having an impact on the taper in a true study setting is not clear, has not been fully elucidated. But generally speaking, I think it's an effective and reasonable practice, particularly when it comes to Alprazolam and clonazepam. Next slide. The different methods of reducing the dose would be the cut and hold method, and this would be a percentage reduction in per week based upon how much they're taking. So, for example, you might do a 5% reduction. Somebody's taking 20 milligrams of of Valium, and you'd be going down by 1 milligram every 2 to 4 weeks, depending on their comfort level. And this would essentially be the cut and hold model, making a percentage reduction based upon the initial total amount every so many weeks in a stepwise approach, and then evaluating the patient for any withdrawal symptoms whenever you encounter them. This is generally the approach that I use. I'd say the only issue with this, and we wrote this as a con, is symptoms at larger dose reductions at once may be more intense. So you might even make a smaller reduction based upon like the patient's preference and if they have any withdrawal issues during the taper process. Next slide. The micro taper, this is making daily micro reductions with a percent reduction calculated on a monthly basis. This might allow for finer adjustments in symptom control, since commercially available benzodiazepine doses could no longer be reached comfortably. It might be more difficult to essentially dose the medication, but this is off-label. This is not something I've routinely done. In my time tapering people off of benzodiazepines, I've only seen this done a handful of times, and it was particularly with individuals that were very, very sensitive during the taper process. They had lots of withdrawal symptoms with the cut and hold model. And essentially, most of these people were sent to a compounding pharmacy to have the medications compounded for them. Did you want to add to Alexis?
Yeah, I was just going to say, I know on like the peer support and websites, there's a lot of good information. We'll show this of how to do these other methods. And I think for a lot of people that do really experience the severe symptoms, this is the way they find to go. Again, I think many of the folks I've seen, this is like, it's just, I can maybe do the liquid with them, but either because of their psychosocial circumstances, variety of things, like they're not going to be able to get to engage in a more nuanced, detailed process, even if they might benefit from it. So I think that's just something you have to assess with your patients. If they're really motivated, if they're able to, for instance, use a compounding pharmacy, or say get a scale or mix with liquid, and you feel they can do it and do it safely and follow the instructions, then I think that's great. And I support my patients in doing that. But there's others where even trying to come up with a schedule of, depending on a whole variety of reasons, it's just not, I've ended up finding there's some that it's going to be riskier to try to do this micro taper with them than figure out a way to do the cut and hold.
I generally have found too that in the limited number of folks that I've done this for, that it's been best to send them to a compounding pharmacy. I'm thinking about some of the patients I work with, and they're actually making these on their own at home, measuring things or cutting things and dissolving them in liquid. There are so many other factors, like the stability. How much do they make at once? Did they cut up a week's supply? And what's the stability of compounding that at home in orange juice versus having a compounding pharmacy do it? So generally what I recommended is to have a compounding pharmacy do make the doses. And I know Walgreens has a good program. There are a number of other programs that have worked well for people.
The other thing I have done, but works more if you're doing, like, if you're able to do the reductions with, say, diazepam, is have recently learned CVS's simple dose pill pack program will do even half tablets. So if you have someone that's having trouble keeping track of the plan and you're going to not make a change, at least, I mean, you're going to do it scheduled and not change more than every month, they will send the patient with these packets or deliver it to their house that are, time stamped. This is the day time you're supposed to take this. This is all the medications you're to take at this time. Yeah. So that's another way.
Yeah. And I think that these are the dosing increments, the tablet strengths that they make of some of the most commonly used benzodiazepines. And what's remarkable here too is that somebody actually wrote in one of the questions too, is more of a comment, that 1 milligram of clonazepam is nearly 20 milligrams of diazepam. And so reducing the dose of clonazepam by 0.25 milligrams, it sounds small, but that's essentially like decreasing the dose of diazepam by 5 milligrams. That's a 25% dose reduction. That's going to be likely too much for somebody. And so
yeah, when I was just going to say, when I referred to it as lower dose, I don't mean that I actually consider 1 milligram of clonazepam a low dose, but the truth is, if the FDA approved max is 4, and I not infrequently get referred patients that are on 3 or 4 milligrams of clonazepam or alprazolam. So even, the knowledge we have, especially knowing of trying to engage folks in tapers and the potency of those of alprazolam and clonazepam is different than what is, what has been practiced and what is FDA approved.
And I think that's why, as you were saying, that we often transition people to diazepam, because you can get to a smaller dosage increment just by virtue of the potency of the medication itself and the tablet strengths that they make. A 2 milligram tablet could be easily cut in half into 1 milligram. That's a small percentage of, you could just get to a smaller dosing increment. And even with the clonazepam, Dr. Ritvo and I were discussing the ODT, and as a way to get people down, if they want to stay on clonazepam, going down by a really small dosage reduction. I can also say, when it comes to the orally disintegrating tablets, they are more expensive. That's not something at the VA that I have access to, as orally disintegrating clonazepam. And generally, if somebody needs dose adjustments that are that small, those would be the type of folks I would try to convert to diazepam.
Yeah, and as you mentioned, you still have to swallow the medication to get the effect. It doesn't absorb sublingually. They're crumbly, so cutting them in half for most people doesn't work particularly well, and expensive. So it's an option if patients feel strongly about not switching, but there are limitations to it. So I think those are important. I will say too, I think previously the practice, at least in the United States, had been thinking of clonazepam, I can't speak, as a long acting that people could be transitioned to. And I think we've moved away from that. I think Ashton already knew that and speaks about that because of its potency and the fact that you're really limited in the dose reductions.
And this would be an example of an old taper that was provided. Like this was a taper that I utilized a long time ago. And this is actually from Ashton's, this is actually in part developed from Ashton's website. But when I look at this now, this to me would be incredibly, this would be fast. And these would be large dose reductions, but this would be something in my mind that many people would look at this and would initially think and find it to be reasonable. And I'm not saying that it's not, but it would be a pretty marked reduction right out of the gate. by a large amount, and perhaps in like intervals that are too short. But this is something that people were taught, and this is also something that this is something I have used to teach over the years. And when I look at it now, this seems like a reduction that would be too quick and would be too much at once. But this is something that has actually been used to teach before. Any thoughts or comments on this?
I was going to say, even with diazepam, I guess a few things I found. We didn't put the equivalency table in here. It is on the de-prescribing guidance. But knowing that, one, some people are more sensitive to the sedation from it. And so, that's another reason why you do want to do a gradual cross taper. I have an occasion, like I have someone I'm trying to taper right now, where I don't want to put them fully on diazepam given age and cognitive impairment until I get to lower doses, but they were having too much interdose withdrawal, even with 4 times a day dosing of Alprazolam. So I've substituted a small amount of the Alprazolam for diazepam at bedtime, just to see if we can't get a little more stability. And I have another patient I can think of where even 3 times a day a dosing of diazepam, whether they might be a fast metabolizer or just the behavioral effect of diazepam on anxiety is shorter than the actual med half-life. So I found that dosing it 4 times a day, dividing the dose 4 times a day, has been much more helpful to make them tolerate than doing 3 times a day. So I think you have to, there is nuance, and you really, I think, going slowly, working with the patient and kind of thinking about, are there ways to make adjustments? And of course, the importance of writing things out clearly. I think I double check whatever I write out and what I write for prescriptions, and still, so my patients know, sometimes make mistakes because, of course, dealing with all these fractions, it's easy to kind of get yourself in circles. So, okay. In the interest of time, so we only have 2 minutes left. I can stay for questions, and certainly we'll provide you all with these slides. I think we'll just mention quickly, overall, when thinking about other adjunctive medications to help with withdrawal, there's not good evidence. Overall, usually withdrawal symptoms are best managed by adjusting the taper rate, engaging in non-pharmacologic measures like the lifestyle modifications, peer support, psychotherapy. There is some good evidence for the use of psychotherapy, mostly cognitive behavioral therapy. There's some protocols that have been used specifically in tapering benzodiazepines and have shown that they can increase the success of the tapers and future abstinent rates. Of course, we previously mentioned, that using CBT for insomnia and anxiety is also useful. And then I'll let Jeff talk about the other medications.
Yeah, we're talking about other medications, particularly. Actually, we'll just go ahead and jump to the next slide in the interest of time, just to talk about it. But essentially, there are some medications that have been looked at to be used during the withdrawal process. 1, to mitigate withdrawal symptoms, and 2, in some circumstances, to replace the use of tapering of benzodiazepine. This is not something that I would ever advise doing. Again, the data on this is really limited. Some anticonvulsants specifically have been studied: carbamazepine, valproic acid, and its derivatives, oxcarbazepine. Among those, only oxcarbazepine and pregabalin have demonstrated some efficacy in reducing withdrawal symptoms. And the potential benefit of using these things would be to complete the taper in somebody who needed to be tapered off of such medications, to avoid the precipitation of significant medical withdrawal. But you do not feel that using a benzodiazepine is safe because of very, very specific patient factors. Let's say that the patient picks up the prescription of the benzodiazepine and takes them all that day, and then presents to the ER the next day saying, I don't have any benzodiazepine, I'm concerned about going into withdrawal. And I've worked with, this would be a pretty limited population. And in those instances, I've actually seen one such person hospitalized and put on a benzodiazepine taper over the course of a week, and was kept in the hospital and then discharged with some amount of Tegretol, and which I then followed this patient afterwards. But this would be a pretty rare circumstance. Yeah, generally speaking, it would be, in only the most extreme of safety related issues. But
yeah, where the risk of them having even a weak script for a benzodiazepine, it is too risky. So usually whether it's addiction or just other severe cognitive impairment or such poor impulse control, which is not the vast majority.
Yeah,
of
this is such a small subset of, I think, one instance of like this, but these medications have been essentially used to reduce withdrawal potentially. Yeah.
So we'll just wrap up. I want to, you'll all get these slides. The rest of them are actually pretty repetitive. Some of them talking about overall potential pitfalls, things we've talked about in the last few sessions. But I think, again, patient-led, I think the things I repeat again and again to the residents I supervise are, you're on the same team as the patient. This is a marathon, not a sprint. If we can even get a patient on less benzodiazepine over time, then that's, going to decrease the long-term risks. And for some patients, the risk of decreasing or getting them off may still be greater than the risk of keeping them on. And it's just an ongoing conversation and evaluation. One of my colleagues, an addiction psychiatrist at Oregon, that's on the Alliance for Benzodiazepine Best Practices for me, just published a commentary in JAMA Psychiatry about something called chronic benzodiazepine, complex benzodiazepine dependence. I'm getting it not quite right, but that is parallel to the idea of what we've seen with opioids, that there are some patients that it's not addiction, but they're physiologically and at times psychologically so dependent on these medications that their risk of destabilization and severe disability coming off them may be greater than keeping them on. But again, this is an ongoing evaluation. There's some patient where that's the case until some sort of insult, injury, medical issue where it becomes clear that then the ongoing risk of them staying on this. And I have patients who are on the medication for 10, 12, 15 years. And then as they get older, because of cognitive issues, other illness, falls, it does become necessary that we try to get them on less, if not off. But you just have to see. Thank you, Christy. Got it. I was too tongue-tied. Complex, persistent benzodiazepine dependence.
I just want to, if I could share, I wanted to echo the same thing. It's been my experience. I feel like this is a really important comment to make, is that there are many people that I work with where I don't know that getting completely off of benzodiazepines is the right thing for them, but they do worse, they feel worse, they've been on the medication for long enough that the process of tapering is really difficult, or being off the benzodiazepine for 3 or 4 or 5 months, and they just think, I just really felt better. And I think that there's room for that in this. And in fact, it's important, I think, for many people to have access to these medications in that way. And I think at one point in time, I was more clear and maybe pushed people more to see if they could get off the medicines. And now I hold more of a place that I call curiosity, that I'm curious about how you would feel and if you would do better and what it would be like to be off these medicines. But I think I hold the space that many people may stay on some amount of these medications long term. And once they've been on them long term, there are those neuroadaptive changes. And so oftentimes when I'm most strict about benzodiazepines is when starting them, which is very rarely, and usually for just, again, small short-term course for an acute stressor or trauma, and with a really clear understanding and lots of informed consent about the medication. But for people who've been on it for many, many years who don't have explicit safety concerns, sometimes it is the best thing for them to have to stay on some amount of medicine.
Yeah, and I think I saw someone ask, are you not still worried about tolerance and other symptoms? Yes, and I think that's part of the ongoing education of what is working for you now may not be what works for you down the road, and what would be is there anything you have noticed? Is there anything, can I educate you about what my concerns are with the long-term use of these, or what would be signs or symptoms that we need to begin trying to decrease? But I have seen patients just when it's forced, you don't have their psychological buy-in, they're already worried, and they can do worse. There's some patients, especially with other complex psychiatric issues, where again, well, I wish many of them were never started on this. They've been on them a long time, and their neuroadaptation is such that trying to get them off, or it is going to destabilize them greater. They end up in the hospital, either medically or psychiatrically, repeatedly. So I think, again, it's a case by case basis, and the big message is go slow and really work with the patient.
Well said.
So, well, thank you all. And as always, there's so much more we could discuss, but you'll get all the slides, and appreciate everyone that has been able to stay on. Take care. If anyone has questions, they're welcome to ask. I think a few of us can hang around. Okay, well, seeing none, then I will adjourn the session.
Thanks, everyone. We'll try to get the recording posted later this evening.